Okay, and good afternoon, everyone. Thank you very much for joining our IPAC-CSO clinical round session today on CJD. With us today is Nicole Gallagher from Niagara Health, who's going to be our presenter today. As you're filing into the room, if you could please take a second to complete our demographics poll. As I was saying, this is being recorded and will be available online for future viewing. And we will be doing IPU certificates for today's session for the live audience only. So anyone watching this recording after the fact, unfortunately, IPUs are only available for the live viewing of this. On the note of IPU credits, the way that we will be doing it today and that we do it for this series is when you exit the Zoom meeting in your web browser, you should have a pop-up with an exit survey. That will have the opportunity to enter your name as you'd like to see it on the IPU certificate, the email that you would like that certificate sent to, and an opportunity to share any feedback with us, request any future topics, anything like that. If you, for whatever reason, don't get that pop-up or that web browser survey, or if there are multiple of you joining from one device, you can just feel free to email myself, and I'll make sure to get the IPU certificate set up for you. It is a manual process of creating these IPU certificates. We like to give that slightly more personal touch of actually having it as a PDF with your name on it. And I just do that one evening sitting in front of the TV watching Netflix and powering away on the computer. So it won't be an instantaneous process. Give me a week or so to power through that. With that out of the way, we'll introduce our speaker for today. So Nicole Gallagher is a CPAC certified infection control practitioner at Niagara Health. Nicole oversees the ICU, pediatrics, women and babies, and NICU programs. Nicole has an honors Bachelor of Science from Brock University in neurobiology, an advanced diploma in science laboratory technology from Fanshawe College, a medical lab assistant certificate from the National Academy of Health and Business, and our IPAC course from Centennial College. In her role as an IPAC practitioner, Nicole has led or is a lead for the antimicrobial resistant organism and laboratory teams and has proudly been involved with many initiatives, including candidemia in critical care, sepsis awareness campaigns, lab construction for the South Niagara site, and development of a suspect CJD lumbar puncture kit. When she's not helping to curb the spread of infections in her hospitals and her region, you can find Nicole paddling the backcountries of Ontario with her husband and her 3 adventurous children. All right, with that, we will turn it over to Nicole, and you may feel free to take it away.
Thanks so much, Kevin. It was a very kind introduction, and thank you to the IPAC-CSO team for your support with this presentation today. I also want to send a special thank you to my colleague Brandon De Silva for the invitation to present and to speak today. My name, as mentioned, Nicole Gallagher, and I work at Niagara Health as an ICP. This topic is near and dear to my heart, and it draws on those remnants of university that are somehow banging around in there in the back of my brain. So for Prions' sake, let's talk about safe handling for IPAC procedures, safe IPAC procedures for CJD suspect patients. So our agenda today, we will look at prions, how they cause disease. We'll go through the process of human transmissible spongiform encephalopathies, also known as TSEs. We will discuss Creutzfeldt-Jakob disease, pretty specifically CJD, both the clinical concerns for suspect and positive cases, and also with IPAC-related handling practices for testing and processing of these specimens, according to current PHAC guidelines, Public Health Agency of Canada. And we'll also delve into the future state of suspect CJD handling recommendations for CSF fluids, new recommendations that are coming down the pipe from the National Microbiology Laboratory. So prions, the term is actually derived from proteinaceous infectious particles. It refers to a structurally altered version of a naturally occurring cellular protein that is called the cellular prion protein, otherwise known as PRPC. These exist across all human membranes, but more specifically within neurons, also in animal tissues as well. PRPC exists in the human body, as mentioned, mostly in neural tissues, and of course, those are the building blocks of our nervous system. So when PRPC becomes misfolded by any means, it can create a cascading effect and result in a conglomeration of these abnormal disease-causing prions. No immune response is triggered when this occurrence happens because, unlike most of our concerns in the world of IPAC, there's no virus involved. There's no bacteria. We have no fungi that are causing these changes, no parasites either. So diseases caused by prions vary in presentation, but all of them are caused by this simple change in structure. It's a naturally occurring protein, as mentioned, and diseases are classified by their incubation periods and their neuropathology. So in this image here, you can see the normal prion protein, or the normal PRPC protein, the cellular prion protein. It has mostly alpha helical structure. The disease-causing isoform, however, has more beta sheets in the structure itself. And this misfolding and this cascade is what disallows cells from their normal operations, thereby causing either dysfunction or death in these cells that are affected. Prions require extremely high heat, often incineration, for any degradation. They cannot be denatured in the same manner as other disease-causing agents, like those that we're normally concerned about. Human transmissible spongiform encephalopathies are going to be our focus of today's conversation. Although these diseases do exist in animals, such as scrapie in sheep or goats, chronic wasting disease in deer, elk, and moose, and bovine spongiform encephalopathy, also known as mad cow disease, which everybody has heard of course, in cattle. TSEs are uniformly fatal diseases. They're caused by the accumulation of these prions in the human brain, and they cause a cascading reaction of this single prion forcibly modifying neighboring proteins, creating large pockets within neural tissues that can result in negative clinical presentation. The prion's lack of DNA or RNA makes targeted treatments very challenging because normally drugs are manufactured in a manner that targets replication. Because these don't have a specific replication path, we end up with the challenge of not being able to target that specifically, and treatment becomes very challenging. TSEs have a handful of methods of acquisition, and they vary by disease, but these methods generally include sporadic conformational change, as shown in the previous slide, where one modified protein impacts another protein next door, creating that change in structure. Sporadic genetic mutation can be implicated. So these are mutations in the gene that actually encodes PRPC, and they can lead to production of abnormal proteins that are more prone to misfolding. Whether they misfold initially or not is subjective. So there's actually a multifactorial expression required. So it may not be just that the protein coding occurs. It may also be that the expression does not occur, or maybe later in life. There's also the possibility of vertical transmission by hereditary means. So these genes encoding PRPC are autosomal dominant. So if one parent carries the mutation, each child has a 50% chance of acquiring that gene mutation as well. And if you've ever donated blood, you'd probably be familiar with that typical donor questionnaire question that exists, referring to CJD. Often, if there's any family history or any risk of exposure, you would be removed from donor possibility. And then, of course, there is also horizontal transmission, which occurs by contact with infected tissues or biological fluids. So TSEs in humans or in animals are all uniformly fatal, as mentioned. Treatment focuses on providing comfort measures only. Some examples of human TSEs are CJD.
Sorry,
That's spelled the acronym.
sorry, Nicole.
Yeah.
Are you moving your slides forward, or are we still on the same?
We're on this one, yeah.
Okay,
Sorry,
just
I'm
double
still
checking.
chitter-chattering away. I apologize.
Absolutely. No, it's all good.
So Creutzfeldt-Jakob disease, CJD, it will be discussed further in this presentation. There's Gertzmann-Straussler-Scheinker disease, GSS. It's extremely rare. It's almost always inherited, and it's found only in a few families worldwide. So when we talk about testing of CJD, we're also including these others. However, they're so rare that generally the most common is Creutzfeldt-Jakob disease that we're discussing. This GSS is only in a few families worldwide, as I mentioned. It causes progressive ataxia, dementia, other neurological symptoms. Average onset is around 44. Life expectancy from onset of disease to death is about 2 to 10 years. With fatal familial insomnia, this is a very unfortunate ailment. It's also inherited generally. It's very rare. It causes progressive insomnia that worsens to the point of coma and death. The average age of onset for this is 40. Life expectancy is from about 7 months to 6 years, so a little longer onsets than CJD. And the last one to mention here is Kuru, which was identified in the Foray people of Papua New Guinea in the 1950s and 60s. And it was linked to the practice of ritualistic cannibalism in funeral rituals, which was widespread among the tribe for all ages. So in these cases, it was identified that TSE developed over patients or people in the age range of 5 years old up to 60 years old, with a life expectancy of only about 3 months to 12 years. So very wide range, however, could be extremely short or much longer from the onset of symptoms. Here we go, Trish. Next slide. As discussed, TSEs are uniformly fatal. They're rapidly progressive neurodegenerative diseases. They occur by that way of the domino effect cascade with those protein isoforms in the neural tissues. No immune response occurs because there's no invasive pathogen. There's no inflammation. There's no reaction that our bodies take. It's just all of a sudden we have clinical symptoms that begin to occur. And unfortunately, by the time those begin to occur, the cascade effect is already taken over, and it's only a matter of time. So in humans, the following symptoms have been reported. We see a lot of behavioral changes, such as personality changes, depression, confusion, commonly reported as early symptoms. The neurological symptoms seem to show up a little bit later. They include difficulty with balance and coordination, your ataxia. We've got tremors, myoclonus, so involuntary movements, sensory disturbances like hypersensitivity to touch or sound, light or hallucinations, nystagmus, so involuntary eye movements or visual deficits are also reported. And as the disease progresses to later stages, of course, loss of function becomes predominant. You end up with coma, unfortunately, before death. So CJD, Creutzfeldt-Jakob disease, there are 2 general classifications, classic CJD or variant CJD. Classic CJD has 3 general categories within it. The determination of the cause is made through investigative efforts of a patient's familial background, their social background, and their medical history. Classic CJD is primarily caused by sporadic mutation of the gene that codes for the production of that cellular protein. So that accounts for about 85% of cases. It's just a sporadic mutation. There's no specific identification as to the cause. This is still a very widely studied topic, and we'll see if someday we get a little bit more answer on that. 5 to 15% of cases are linked to genetic inheritance, and less than 1% are related to healthcare intervention. These account for cases involving, say, transplant of infected neurological tissues, maybe exposure to insufficiently reprocessed medical tools. So let's just remember, I mean, prions are extremely challenging to destroy, and they often resist standard medical device reprocessing. So this is a major consideration, especially from an IPAC lens. Classic CJD is not caused by another prion disease. So there is no acquisition, in this case, from ingestion, like there would be with with our variant CJD, which we'll talk about in a moment. The range of the disease onset here is from 55 to 75 years, so much older population generally affected. The average duration of illness is about 4 to 6 months, which is pretty quick in the realm of TSEs. Clinical signs are very similar to those discussed already. We would be looking at rapid progressive dementias, memory loss, personality changes, hallucinations, speech impairment. Whereas variant CJD, on the other hand, is caused directly by a different prion disease. It's caused by ingestion of beef that was contaminated with BSE, bovine spongiform encephalopathy, also known as mad cow disease. Often CJD gets termed exactly that, strictly mad cow disease in humans. It's actually not that. However, variant CJD is caused by mad cow disease ingestion. So the method of transmission here is actually by ingestion. The prion accumulates in lymphoid tissues in the spleen and lymph nodes, and then it spreads to the brain, where that transmission then occurs, creating the domino effect within those proteins in the brain. So the majority of cases from variant CJD are actually linked to the United Kingdom public health crisis in the 1980s and 90s. As of 2024, 233 clinical cases have been reported. Tissue screening in the UK, completed for a study in 2012, also estimated that 1 in every 2,000 UK residents is infected with the disease. As we spoke about, actual expression of the disease is multifactorial, so it could be that these prions were detected in these individuals. However, actual clinical presentation was not necessarily there. It involved mass incineration of cattle. The duration of illness in these cases are much longer. However, the age of onset was much younger. So the average age of onset here, about 28 years old, and the median duration of the illness was from 6 months to 4 years. So longer period of time until death. However, age of onset was affected. In a similar vein of concern, and something to mention here, chronic wasting disease is that transmissible spongiform encephalopathy that is linked to deer, moose, and elk, and its incidence is increasing. Now, although there hasn't been any direct link made to human disease related to ingestion of meat from those infected tissues, there is concern that, down the road, maybe something will be found. And even if not, public health recommendations are very strong to suggest not eating any tissues from meat from animals that may be confirmed with TSEs or exhibiting unusual behavior. So some clinical considerations from the world of the humans. Method of diagnosis of TSEs involves, once again, evaluation of a patient's medical history, as well as the progression of their symptoms. So we will often look to see a neurological exam involving assessment of their reflexes, coordination, any muscle twitching or myoclonus, or other neurological signs. There's also usually a brain MRI as well as an EEG completed in order to determine any abnormal structural changes or any signal changes, particularly in the basal ganglia of the brain and the cortex as well. There's also a lumbar puncture involved, or a spinal tap, for CSF protein panel testing. The newest and gold standard test is considered to be the IPAC-CSO. It's the gold standard test, very highly specific, highly sensitive, and it involves, it's an immunofluorescence assay basically, but it involves a recombinant protein so it's a recombinant protein, that substrate that will convert to misfolded form if it's inoculated. So if we introduce CSF that does contain those prion proteins, it will create a cascade effect in vitro. And then it is also fluorescent, so we can determine if there is a full fourfold increase in that fluorescence, and that would be considered a positive result. For protein assays, the other two that are still used, we use the 1433 gamma ELISA or the mu-tau ELISA as well. Both are still relatively accurate. However, sensitivity and specificity are both less. So gold standard is now our IPAC-CSO. So for suspicion or diagnosis of CJD, patients are not required to be in any additional precautions on a regular basis. It is only when we look for specimen collection or surgical procedures that additional precautions, additional procedures are employed. So for instance, with CSF, when handling and processing any high-risk tissues or fluids, such as during spinal surgeries or brain surgeries, additional care and precaution is required for handling of specimens in transport as well as within the lab, and careful consideration for use of sharp instruments. Any soiling of workspace with suspect tissues is very carefully regulated. And during waste management of materials and instruments as well. And in these cases, additional precautions are added to ensure the safety of patients as well as staff. A true confirmatory diagnosis of CJD or any other TSE actually has to be done post-mortem. So no official diagnosis can be made until that brain tissue is actually examined after death. So the current Canadian Communicable Disease Report, managed by Public Health Agency of Canada, these are the guidelines for CJD that were last amended in 2007. These outline various tissues as either high infectivity, low infectivity, or no detected infectivity. And even in the cases of suspected CJD, any tissues that are deemed no detected infectivity do not require any additional precautions in handling. So these include examples such as saliva, urine, blood, or bone marrow. Hospitals that do provide surgical services involving contact with high infectivity tissues like brain, spinal cord, dura mater, or pituitary, they do have highly regulated processes for management of tools as well as clinical specimens for patients suspected of CJD. So these services often involve incineration. So this is for high infectivity specimens. They involve incineration of any disposable surgical items, as well as quarantine of surgical tools and instruments until a CJ test result is received. So when a negative result is received, instruments can be released from quarantine and reprocessed according to standard MDR, medical device reprocessing standards. When positive results are received, however, IPAC and Public Health Agency of Canada get involved in determining the next steps for the instruments themselves. The primary recommendation is always incineration because, as mentioned, these are extremely challenging particles to destroy. They remain infective for very, very long periods of time, and they don't degrade in any normal way. So for any contact with those high infectivity tissues, we recommend always incineration. However, for any heat-resistant reusable instruments that an institution is unable or unwilling to part with by way of incineration, there is a decontamination procedure and sterilization that can occur. Involves immersion in 1 normal sodium hydroxide or sodium hypochlorite for an hour, followed by rinsing and proper sterilization. Hard surface decontamination involves flooding of that area or those items with 2 normal sodium hydroxide or undiluted sodium hypochlorite. So of particular note, especially for facilities that do not support surgeries of high infectivity tissues, CSF is currently categorized as a low infectivity tissue, as you can see here. However, there's an addendum with the 2 stars at the bottom of this chart that clarifies that instruments contaminated by CSF should be handled in the same manner as those contacting high infectivity tissues in at-risk and high-risk patients. And this addendum, this tiny little piece here, as well as its respective categories within this document, has been referenced by many facilities as the justification for introduction of IPAC practices surrounding the collection, handling, and processing of any CSF specimens for patients suspected of CJD.
You're welcome. Thank you.
At Niagara Health, IPAC practices surrounding these safety procedures for suspect CJD patients culminated in creation of our suspect CJD lumbar puncture kit This kit was developed with a multidisciplinary team at our hospital, composed of physicians, clinical teams, environmental services, quality teams, OC health and safety, as well as IPAC. So when CJD is considered within a patient's differential diagnosis, ordering of CSF testing will trigger a flag to both the lab, and the lab will contact IPAC, or IPAC will be contacted as well. But all three parties, both the ordering physician, the lab, and IPAC all get involved prior to the collection procedure occurring. The suspect CJD kits are found throughout our hospital system, and they're all positioned directly beside a standard lumbar puncture kit in any storage areas where those are found. The suspect CJD lumbar puncture kit includes a standard lumbar puncture tray itself, which of course includes our lumbar puncture needle, as well as our solutions, the drape, impermeable drape, any of our collection vials, that standard kit. And in addition, included in these kits are these three items that you see at the bottom here. So we have a red biohazard bag, which is used to collect all of our linens from the patient's bed where the LP is completed, all of the linens, as well as patient gown, any other items, our PPE, everything that could be in contact with CSF will end up in that biohazard bag. The sharps container is a fluid sealed sharps container, which is used, of course, for the sharps involved in the procedure, so that needle itself. Both of those items get sealed appropriately. And then on the outside of those containers, we place one of these CJD suspected stickers. So that sticker will go on the outside of both the red biohazard bag, as well as on the outside of that closed and locked sharps kit. And those will be flagged and communicated with EVS to take away for incineration. The remainder of the labels themselves will be placed on the specimens themselves, which are then appropriately labeled with the corresponding requisitions completed in miraculously perfect way and sent off to the lab, and which will be sent off to the National Microbiology Laboratory for CJD panel testing. So if CJD is included in a CSF testing panel at our facility, this will be completed first. It's always primary, because we don't want to risk any exposure of our instrumentation, our staff, to any risks with this, CSF fluid that is meant to be handled according to high infectivity tissue standards. All other tests, however, in that vein will be held, and those are subject to degradation. They may not be viable by the time that turnaround time is over, 15 days, and it could affect the specimen viability or even treatment delay. So there's a major concern. I mean, we're doing our best from a safety perspective, but is this the best outcome for our patients? So there are some challenges with the current practice, not just with us, but there's some questions about whether this recommendation is justified. And the challenges that we have identified is that CJD can enter a differential diagnosis late, sometimes with routine samples already having been collected and processed, and maybe it's an afterthought to add CJD testing to a panel. And unfortunately, by that point, often other routine tests have already been completed on the instrumentation, which could expose the instruments to those prions and require either very in-depth cleaning or incineration of instruments themselves. So that can come at a very high cost to the labs. There's also possibility of missed opportunities for the incineration of sharps, PPE, environmental items, according to the suspect CJD protocol. It also could involve staff concerns for exposure. I mean, we have to be aware and remind ourselves, of course, that this is a uniformly fatal disease. So we're not asking a small thing to, ensure that our staff are safe when it comes to transmission of a uniformly fatal disease. Potential for exposure is very scary. So the key question here is, should CSF be handled as a high-risk tissue? What is the actual risk here? This question was recently raised and investigated by Dr. Susan Putanen from Sinai Health System and University Health Network, and Dr. Stephanie Booth, who is the Chief of Prion Diseases at the National Microbiology Laboratory. They identified through their own studies and research that biosafety guidelines for handling and processing of CJD suspect CSF, they vary across the country. They noted inconsistent practices and messaging across the country that contributed to staff uncertainty and anxiety, questions about exposure and risks, implications to deferred tests, like we just mentioned, lost equipment, sometimes in the order of hundreds of thousands of dollars. It's expensive, it's scary, and is it necessary? So Dr. Booth and Dr. Putanen identified that surprisingly few studies have been dedicated to the experimental detection of infectivity in CSF itself. So in a review of available literature, they outlined some key findings, and these were presented last year at the 2024 AMMI Canada CIC-MID Annual Conference Stakeholder Meeting. Some of the review findings included a 2012 study by Buxton et al., which assessed the prion disease risk perception in Canadian medical labs. And they found that there was a very high perception of risk in processing any of these prion-associated specimens. But the conclusion of the study was that national guidelines and adequate training would actually enable lab employees to process these specimens efficiently and with confidence, knowing that their recommendations align with safety in their corner. Another study that was involved included the Alcade-Cabarro et al. Study from 2012. It's a European study that investigated health professionals and the risk of sporadic CJD over the course of 1965 to 2010. They investigated occupational profiles of physicians and healthcare personnel, and they compared sporadic CJD compared to cases and controls in the general community that were not healthcare professionals. And they found that there was no support for increased occupational risk for healthcare professionals. However, there may be specific risk in some professions that involve contact with designated high human infectivity tissue, such as brain or spinal cord. A couple of other review findings here from 2012, Ma, Zhang, and Yan investigated some results from a direct injection of what's called a seed-containing recombinant prion. So it's the equivalent of a very high concentration of prion equivalent to high infectious tissues. So as though you were to take a CJD positive human brain and take a sample of that and directly inject that into mice, they found, incredibly, that the outcomes were wide-ranging, from either completely innocuous with no effect at all to lethal. So that concluded that seeding alone, so the actual introduction of those prions to those tissues, was actually not equal to the expression. So pathogenesis must be multifactorial. And the final study to review here is by Raymond et al. From 2020. And this investigated relative amounts of infectivity of olfactory mucosal brushings, which are neural tissues, but from our olfactory glands within our nose. They're considered to be a lower concentration of prions. Sorry. But not as high infectivity as brain tissues, but still contain, that risk. They used these two samples comparing with the CSF and then with these olfactory mucosal brushings, and injected them into groups of mice, transgenic mice, with each sample type. And the olfactory brushings had a 10,000 times lower infectivity per unit than brain tissue, considered high infectivity risk. And CSF altogether, and in comparison with the control groups, lacked detectable infectivity altogether, no results, even when directly injected to the brain. So this raises some questions and also helps to support some decisions that have been made worldwide. The UK guidelines currently outline that CSF is a low infectivity tissue, period. There's no addendum, there's no handling comment. It just is that CSF is considered low risk tissue alongside urine, blood, other specimens of that nature, and general protective measures are used. So the same level of concern and care would be used in handling suspect CJD CSF samples or standard CSF samples. So this SNP is from the Department of Health and Social Care in the UK. Their laboratory containment and control measures. And as I mentioned, CSF is considered to be a low-risk patient-derived fluid. These next few slides are from that same document. This panel outlines the safety considerations. They're generalized, basic routine practices that would be used with handling of any CSF sample. So these should be used whenever there's a risk of exposure to potentially infectious material, which happens in the lab all the time, including prions or proteopathic seed preparations. So the takeaway here is that no need for additional precautions above and beyond for CSF that is suspected for CJD are required according to the UK. This info box here just keeps with the same process. So any spills or contamination with these low-risk human biofluids would follow standard procedures. And this last one here, more suggestions for handling of suspected CSF. And this is all in line with normal handling of non-suspect CSF fluids. So a summary of this review that was done by Dr. Putanen and Dr. Booth outlined, we have to keep in mind that in Canada, about 70 to 90 cases of CJD are diagnosed per year. And any increase in these cases year by year could be attributed to the introduction of IPAC-CSO, that gold standard higher specificity test, which has a higher sensitivity, of course, than previous methods. You also could consider that the UK guidance considers CSF a low-risk infectivity tissue. And as well, those research takeaways, healthcare worker anxieties are extremely high, according to current guidelines. No meaningful association has been made between occupational risk and exposure compared to non-exposed healthcare workers for these low infectivity fluids. And direct injection of the high infectivity tissues doesn't necessarily result in, expression of the disease. However, CSF, when following the same procedures in lab, shows no change in the actual infectivity. So by way of this investigation, and thank you for following me along with that long-winded explanation, the National Microbiology Laboratory went so far with their confidence level to change the recommendations from their standpoint on the actual website as well as in general. So they've recommended now to call CSF in general that is suspected for CJD a low-risk infectivity tissue. And that is a change from the current CCDR. And it is a recommendation, and it is important to recognize that the national microbiology recommendations are not a replacement for that CCDR or PHAC guidance documents. However, this is something that we are expecting to come down the line very soon. And an indication of that is that in the last year or so, there has also been a follow-up memo from the Public Health Agency of Canada, basically indicating that for those facilities who are interested in following through with a risk assessment for their own populations, there is support to suggest, safety measures would be considered as long as the investigation is complete for adapting this recommendation into their own practice. So as I mentioned, although the CCDR has not yet been updated, PHAC has released that memo in the past year to assist supporting facilities that wish to transition sooner. And some Canadian facilities have already shifted to implementing these changes. This suggests, they are suggesting, as mentioned, that a local risk assessment is done for any activities for diagnostic labs where low risk materials are handled. So CSF, blood, urine, etc. This is, I have to highlight as well, not related to any high infectivity tissues. So the NML has already updated their recommendations online. Some Canadian hospitals have already taken those into account. And for those of us with well-established safety practice in place for suspect CJD CSF, for instance, we have to consider that there are some immediate barriers to implementation. We have to think about the anxieties of our staff members when it comes to, especially when a wide and vast effort has been placed into educating and ensuring that all staff members are aware of processes and the risks to themselves and others in handling of these specimens. We're basically having to have discussions that will take us back and make us all, reconsider what the decision making may have been in the past, and, scientific research that helps to support these changes. These changes could involve resource changes, such as our current suspect CJD lumbar puncture kits, any associated documents and supporting fact sheets. There's concerns about procedural changes, so in the lab environment, handling, instruction, lab collection guidelines. And, IPAC has always played a very central role in assisting in support for clinical and lab teams and making sure that safety is in place. So it's important that we are transparent, we are accessible, and we're available for support and providing references and procedural information throughout this change. And, it needs to be a widespread but also thorough rollout whenever it is that our individual institutions decide to follow through with this change. So this topic will likely be on the forefront for some time and will be required for, it'll require our patience and professionalism in the upcoming time. So with that, I thank you very much for your generosity in sharing your lunch with me. And let me know if you have any questions.
Thank you so much, Nicole. Yeah, I think you're right. This really is your fusing of that neuro background with the IPAC background. What a fun fusion of worlds, right? I do know we have a couple of questions in the chat, so we'll turn to those first. And then if anyone else has questions, they can throw their hands up or throw it in the chat. But perhaps I'll jump in with a first question for you, Nicole. And this might be stretching beyond the bounds of actually known science on it. But in all that digging through the literature that you did. So you had said that kind of direct seeding of infectious brain or infectious material into the brain of mice does not guarantee infection. And is that a consistent across, like, no matter how much the inoculum dose is? So it's more of a host level response, or is it, is it like if you're susceptible, one protein's as bad as 10,000 proteins, or does there still get that kind of eventually you can overwhelm the host anyway and guarantee infection?
Yeah, so with that study, it was associated with an increased inoculation. So you're right. It still was not consistent. It wasn't logarithmic in a typical way. And it really does, depend on the multifactorial consideration. You've got different contributing factors, and presence of those seeds don't necessarily, require that a clinical presentation occurs. But you do also have to consider through those mice models that the lifespan of a mouse is much shorter than the lifespan of a human. So given the potential for, maybe a longer lifespan, it may be possible that we would see presentation of that later down the road.
There's that old adage in
right.
research, mice lie, right?
Yeah. They can only give us so much, although they're so sweet.
All right. So we have a question in the chat from Ronnie. With liver and lung transplants, is it standard practice to screen for CJD prior to organ donation?
Not to my knowledge. I don't know enough about the organ donation side, but those are both considered to be low risk infectivity tissues. So I don't know if it's required, but that's a really good question, Ronnie.
And I know that it's often we pre-screen for surgeries on high-risk tissues, but perhaps if anyone works at a transplant center, they can, if they have different experience, feel free to throw it in the chat. Eva asks, what is it about the malformed protein that makes it so resistant to reprocessing, given that proteins are often heat labile?
That's a good question. I don't have a clear answer on that. I'm sure there is an answer in the literature, but they are by nature very resistant to heat except at higher temperatures, and it must be by incineration. I think that I don't want to, project, but I would imagine there's a change over the course of time with added heat. However, we can't be certain that they're destroyed until, incineration has occurred. And that is only our best effort, right? There's still a chance.
Yeah, fair. Trish, over to you.
Yeah, so one of the high risk organs is eyes. So what is, what is the risk of, eye procedures like cataracts or laser or any of those things? Is there a risk in that scenario?
There is risk for any suspect patients that would be suspect of CJD. Their incineration procedure, especially when your surgical intervention involves the retina or the optic nerve as well, especially those nervous tissues that are directly associated with the eye. But those items, we don't follow through with those procedures at our hospitals. So it's not something that's at the forefront of my understanding. However, those would be the higher risk tissues within the eye itself.
Yeah, we have a large eye clinic doing
Okay.
multiple things. So it was not something on my radar
Mm-hmm.
to think about.
Yeah,
Very
maybe worth
interesting.
an investigation for sure. Yeah.
Just a look.
We're in the
A little
same boat,
look-see.
Trish. Trish, we're in
Yeah.
the same boat. We'll have to talk.
Yeah, well, CJD's on my radar, let me tell you. So yes, thank you. That was a great presentation.
Thanks.
So another question from the chat we have. So given that blood's considered a low risk material, are there any specific tests that can be done before blood transfusion? Or is there any need for specific testing before blood transfusions?
Well, even the detection method that's used for familial detection of CJD is a blood test. And that is not always a guaranteed appropriate response. You're not always going to get a guaranteed positive result, even in patients where they are expressing that protein already. It's not a standard screening test because it is a longer and more expensive test as far as procedure goes. But it is possible you could do those tests, but it's not a regular test that's done for blood testing or for blood transfusions.
I guess it goes back to what you're saying earlier, where CBS, Canadian Blood Services, implements the screening questions as a
Ahead
way
of time.
ruling out those patients instead of trying to do a poor test to catch it.
Exactly. Yeah.
Makes
And
sense.
often, as you know, in the world of blood donation, those samples, especially, or those specimens, especially from people with, say, O negative blood, those are used almost immediately. So sometimes
Right.
there isn't that time, right?
Right, right. Now, I do believe CBS did recently lift at least one of their bans. I think their ban on either receiving blood products in a certain time frame, or maybe it was the living in the UK. So I guess enough time has passed that if anyone would
Yes.
have been exposed back then, they probably would have developed.
Symptoms by now. That's right.
Clotilda asks, what's the risk of tonometers for CJD?
Tonometers. Maybe, sorry, I'm not familiar.
I think that's an eye.
Ocular instrument? Okay.
Yeah.
I believe so.
Yeah, again, I think it would depend on the involvement and which tissues are being used with it, but would certainly be worth an investigation if those are used in your facilities.
Right. Just scrolling through and seeing if there's any other questions. So how far back is the risk if a recently diagnosed CJD patient had eye surgery? And we can maybe extend that out to any surgery on high-risk tissues, months or even 2 years ago.
Well, there is always with every new diagnosis of CJD, because often the way that patients are diagnosed is strictly by clinical, symptom onset. So anytime an investigation is done with a new suspect case, public health is involved in reviewing all surgeries in the past of that patient. There isn't a time frame that it stops at. Of course, more recent surgeries are at higher risk because the concentration of prions in that individual would be higher. But regardless, any surgeries, especially if involving high infectivity tissues, would be included in the possible risk category, as well as, potential risks to other patients. So utilization of any of those reprocessed items.
Imagine the amount of contact tracing of every surgery that may have used any of those implements would be absolutely staggering.
I can imagine, yeah.
All right. Justin asks in the chat, you mentioned about equipment being incinerated. I always thought this applied to surgical instrument reprocessing, but something you said suggested lab equipment might be destroyed. Could you clarify if that's what you meant?
Yes, so both things. Even at our facility, unfortunately, in the last few years, there was an exposure to an instrument, an automated instrument on the line. And when I make reference to $100,000 instruments, I know exactly what that's all about. So with the exposure and in consultation with the Canadian CJD surveillance line, a determination was made to destroy an instrument that had been exposed to CJD confirmed CSF, unfortunately. But these are the types of discussions, and the reason for this discussion and the possible change of direction it's multifactorial. We're considering all of the impacted instruments, surgical instruments included, as well as lab instruments, and the risk, the actual risk to our staff and to our patients.
Presumably, if CSF gets dropped off of that possibly low, possibly high list, then maybe
Exactly.
that $100,000 piece of equipment gets saved.
Yes, and we can wish that there was maybe a time machine that could change the past, but yeah.
All right, and we have one more question in the chat right now from Jennifer. When CJD is included in a differential diagnosis, is it automatically reported to the health unit? If not, when? And perhaps, maybe I'll say is that reported, or should that be reported then at that we suspect it level versus just the confirmation level?
Yes, we should report it to public health at the suspected level. So when we are aware, we should be notifying them. That I think will help to trigger the investigation piece on the side of public health to get ahead of things, but also to assist in any contact tracing. They're involved in a lot of the decision making with these cases as well. So the earliest that we can notify, the better. But it is on our reportable diseases list, yes.
Also, of course, then when you hit the challenge of the physician saying, well, I don't really think it's CJD, but we're going to test for it anyway, just to cover our bases, especially like you said, if you're then deferring often other time-sensitive testing that maybe might have a much higher pretest probability. It's that balance between patient outcome and safety.
Yes, and that is the most directly applicable concern when it comes to the categorization of this tissue as, being handled as a high infectivity tissue, even though generally it's considered a low infectivity tissue. So that is our major concern, and we've run into that many times. I'm sure others with similar kits or procedures to what we have at Niagara Health have run into the same, where, there's it enters the differential, but it's not really part of the differential. They're just considering it. You know what? Let's just test it anyway. Well, there are downstream implications to the other tests in those cases. So you're absolutely right.
All right, Trish, we'll go last point over to yourself, and then we'll just do our closing remarks and call it a session.
Yeah, so one of the things that our lab has pointed out that many physicians do request the CJD testing after the fact. So the specimen has been in the lab or been sent, and then it's, they get a phone call a week later saying, oh, can you do this? Can you do this? So it's really, really important to have those policies and procedures in place. So, the physician is thinking about these things at the time of doing the LP to help, decrease those risks to staff exposure that potentially can happen, even though it is a low risk, but it does cause an increase in anxiety to our laboratory staff. So thanks very much
Certainly.
for a great presentation.
Thanks, Trish. And yes, I agree with you there. That's for sure. We, and I mean, even for the physicians that are conducting the LP, they have to be aware that there's risks to them during that procedure too. So to everybody involved, I mean, we need to really take a good hard look at this process and hopefully there's a better future in store.
All right, well, with that, we'll call the session to an end. So thank you, Nicole, very much for sharing your time and your expertise with us. Thank you, everyone who attended. As we said, this session has been recorded and will be available online for viewing at a future date. As you're exiting the session, you should get a pop-up with an exit survey inviting you to input anything or your email and name for IPU certificates and any feedback you have for this session. If you, for whatever reason, don't get that pop-up and you're looking for an IPU certificate, please shoot me an email. I've thrown my email in the chat there. And of course, just a reminder for anyone watching the recording of this after the fact, IPU certificates are only available for those who attended and watched the in-person session. With that, thank you all so much. Thank you again, Nicole, and have a great rest of your day.